Good evening, everyone. Welcome to tonight's town hall featuring or starring Michael Sequeira, MD, Public Health Officer for San Bernardino County. I'm Alice Nelsner, and I'm the Executive Director for the San Bernardino County Medical Society. Dr. Sequeira will be covering a lot of ground tonight, including updates on COVID vaccination programs for both adults and, as of this week, children, COVID variants that are more likely to affect residents here in the Inland Empire, and approaches toward achieving vaccine equity. We will also hear about the current epidemics of congenital syphilis and STDs. Following Dr. Sequeira's presentation, we're looking forward to taking your questions, and that will be at around 6:45 p.m. We invite you to submit your questions on the chat feature of your Zoom screen dashboard, or you can also use the raise hand icon to ask your question by voice. But for that, please wait until we reach that segment of the program. Couple of notes, please be so kind as to keep yourself on mute while Dr. Sequeira is speaking. And as I say, we will facilitate all of the questions at the end of his presentation. So with that, let me go ahead and introduce our star of the show tonight. I'm pleased to introduce our presenter, Dr. Michael A. Sequeira, Health Officer for San Bernardino County Public Health Department. Dr. Sequeira received a Bachelor of Arts in Zoology from Pomona College in Claremont and graduated with his medical doctorate in the top 10% of his class from the University of California, San Diego School of Medicine. He completed his residency in internal medicine and emergency medicine at the University of Oregon Health Sciences Center in Portland. For the past 30 years, Dr. Sequeira has worked in leadership roles at the local, state, and national levels, including as regional director of 6 of its hospital emergency departments, including hospitals in San Bernardino, Apple Valley, Colton, and Redlands. He is past president of the San Bernardino County Medical Society, SBCMS, woohoo,
Hooray.
From 2016 to 2017, and he currently serves as a delegate to the California Medical Association's House of Delegates through SBCMS. He is a member of the steering committee of the Inland Empire Opioid Crisis Coalition, where he was instrumental in developing an educational program for opioid prescribing and overdose treatment and prevention in hospitals and the community. He also serves as National Risk Director for Vituity Healthcare, where he has been charged with keeping providers current with the latest clinical and research data on COVID-19. So with that, we are so very honored to welcome you tonight, Dr. Sequeira. Take it away.
Oh, thank you, Allison. And it's just a pleasure to be here. And more than anything, I'm a physician and a member of the Medical Society that happens to be the health officer at this time. And I take great pride and will always try to represent the Medical Society. So I appreciate this the time and everyone coming at 6 o'clock around dinner time. If you want to eat while we talk, that's completely fine as well. So what I want to do today is just provide you all of you with kind of firsthand knowledge of what's going on with obviously our pandemic. Give you some recent stats. I've got some questions that have already been submitted. So I have a presentation that will answer most, if not all, of the pre-submitted questions. But I want to hit some of the hot topics. Our incidents, our where we are in our tiers, and vaccine side effects, CVST from Johnson & Johnson, and we just had a recent press release on the most recent stats on CVST, but also deal about vaccine hesitancy and the important role that everyone, especially the physicians and medical society and medical providers, need to play in this last phase of vaccination. So I'm going to share my screen now. And hopefully you can see all this. So we're currently, as everyone knows, we're definitely, we've flattened and come down the steep curve of that huge peak that was in late December, early January, which basically stretched every seam of every hospital within our county. And we've very rapidly come down from purple to red to now moderate. And you can see the criteria. And this is called this is all according to the quote blueprint that the governor's office and the CDPH, the California Department of Public Health. I'll say CDPH, but I think everyone will know it's the California Department of Public Health. It's actually, we're the county public health, and then the state level is CDPH, and then the national level is CDC. So just to clarify. So anyway, the CDPH actually developed this blueprint for closing and then opening. And these are the criteria in terms of case rates, positive tests, and then equity metric positive tests. So we're currently in a low moderate. Our current stats today, we've only had 61 positive cases in the last 24 hours, and our actual case rate now is 2.7, and our positivity rate is only 1.3%, and our equity rate is 1.6%. So we're really perched right on the edge of yellow. Unlikely that we're going to probably hit yellow before the other important date, and you probably, most of you know, but the governor has announced that on June 15th, we're going to get rid of this entire blueprint. It's going to end. And so no more, you can see that the orange tier, the social gatherings, the retail shops that are open. These are all the criteria of the orange tier, and it's progressively more open with the yellow tier. So as of June 15th, all of this is going to be gone. And you can imagine what we're trying to do. We're going to have to vaccinate as many people as we can before June 15th. And that's what's created the urgency of the current last phase of vaccination. So I'm going to already pass that because that was yesterday's data. We're again, yesterday's, we've been expanded to ages 16 and above for Pfizer, and that's it. And not for Moderna, not for J&J. They're both at 18 yet. And right now, the Western States Vaccine Safety Review Board, which is the California equivalent of the ACIP, which is the ACIP is the Committee on Immunization Practices. That's the national. So the FDA has to approve, and then it goes to the ACIP, and then it goes to the state, which is the Western states. So it's been passed by CDC, and also all the safety data, and also the ACIP, and then finally the states, Western states, which is California, Oregon, Washington. All of the scientific people for immunization practices are reviewing that tonight even, and we should probably be approved by tomorrow or Friday for ages 12 to 15, and it's going to be, the doors are going to be opened up then to vaccinating children, so down to 12. Already Pfizer has submitted that they're already studying and going to be submitting probably by late August data, and also probably requests for approval from ages 6 months up to 12. So it's going to be, those trials are going on now as we're looking for final approval for age 12 to 15. The equity thing is really important because patients and our African American, Latinx, and indigenous, as well as our Polynesian patients, definitely have anywhere from 3.5 to 4 times the incidence of COVID, and also 3 to 4 times the mortality from COVID. So it's essential that we actually look at the equity vaccine, what we call equity vaccination. And what we've done is divide up the county by zip code by the quartile of what's called the HPI, or Healthy People Places Index. And a Healthy Places Index is 18 different indices of community well-being. It includes income, housing insecurity, food insecurity, access to medical care, et cetera. So they divided up our county and all the counties into areas by zip code, by Healthy Place Index quartiles. Quartile 1 is the lowest. So what we've done is look at every quartile 1 zip code in our county, and we're really focusing on that right now because A, we're getting more vaccine for it, and B, they're much more prone and they're much more difficult to vaccinate. So this basically is the webinar that the Medical Society put out for the pediatricians, and it's actually to get the pediatricians how to teach them how to enroll in the vaccination program, and it's full. So we've had a great response to that, and the goal, of course, is not to get the county to vaccinate, but to basically disperse it. We've got almost all the pharmacies. We've got hospitals. We want the physicians' offices, and specifically for children, the parents really trust their pediatrician. So we really need our pediatric groups and pediatric practices and family practices to step up and really take this on. And the Medical Society in Soteria Cobb has been a liaison to help enroll physicians into the myturn.com, and it, that's going to be the final step. That's really going to hopefully take us forward. I'm going to go back to this. I've been working, and we as a public health have been working with a lot of what we call community-based organizations. So Inland Empire HIV Planning, the Young Visionaries, the Mexican Consulate, El Sol, African American, their group called COPE and ICAC, and basically, we need to get out and into the faith-based communities, and it's been shown that basically people who have vaccine hesitancy listen to people they trust, and people they trust include their ministers and their congregational members, and more importantly, their physicians and physician offices. So that's the push, and I'm going to get into vaccine hesitancy in a second. I want to talk a little bit about this Johnson & Johnson pause. We rolled it out, and we were excited because it was a one dose is all. And then what we found that initially there were 7 cases out of 7.8 million of Johnson & Johnson vaccines who developed this peculiar thrombotic complication in the brain called CVST, cerebral venous sinus thrombosis, which is kind of a rename of VITT, which is vaccine-induced thrombotic thrombocytopenia. They created the VITT because it's very similar to HITT, which is heparin-induced thrombotic thrombocytopenia, and it's this clot in the cerebral venous sinuses that's associated with low platelets. That's what, for the lay people in the audience, that's what thrombocytopenia is low platelet count. So it's thrombotic, which is a clot in the plate with low platelets. So it's a good screen to get a platelet count for VITT, or vaccine-induced thrombotic thrombocytopenia. So the actual incidence of cerebral venous sinus thrombosis without any vaccines is about 15 cases per million. Okay, so we actually saw 15 cases in 8 million, which is 1 per million. So it actually is lower than the actual overall incidence. And there was just a report by the vaccine, by the CDC vaccine safety, and I jotted it down. I don't even have it on the slide. And that rather than 15 cases, so far they've opened it up, and there are 28 total cases, and 6 were in men, and the highest risk group are women in the ages of 30 to 39 and 40 to 49. And there was women from the age of 30 to 49. So the lowest risk people are men, just in general, and also women over the age of 50. So and the incidence of CVST or VITT are significantly lower than the average incidence in the population for men and women over 50. So, so what we've created a fact sheet for this, and if you're administering Johnson & Johnson, it works. It really is safe. This is a peculiar complication, but it's treatable. Just to get quickly into this, because I want the physicians in the audience to be able to recognize this, but the CVST presents with severe headache, blurred vision, and they have papilledema when you look in on their fundi. And they have evidence of increased intracranial pressure. And the way to diagnose it, probably from an algorithmic standpoint, is just to do a platelet count. If their platelet count is 50 or lower, then and they have this, and they've had the vaccine within the 3 weeks prior, then you really need to do a CT scan with a venous perfusion study, or an MRI with a venous perfusion study. So that's the algorithm. Johnson & Johnson within 3 weeks, severe headache, papilledema, blurry vision, you get a platelet count. If it's low, get the CT scan. It's treatable. And this is due to actually the cross reaction of the antibodies to the platelet factor 4. So it suddenly causes the platelets to clot up. The treatment is anticoagulation, but not with heparin, because heparin can make the same, can create the same phenomenon and make it worse. So that's the key. So the thrombin inhibitors like Eliquis, Pradaxa, those are the agents that you want to use to treat it. So that's a little something on the Johnson & Johnson, and we can open it up for, when we have open questions as well. Basically, in terms of our vaccination sites, there are 13 set county sites, and these are the sites. And we've actually got over 50 different mobile type operations moving throughout the county right now. We still need to do better, though, especially on our equity vaccinations. So, and these are the vaccinations. This was as of a day and a half ago, but we've had 1.2 million. Just for reference, there are 2.1 total people in our county, so we're up to 1.25 million given. Partially vaccinated, 724. Fully vaccinated, 568,000. So we're actually moving along. We're close to 45–50%. And when you look at seroprevalence, which is it's the people who are vaccinated plus the people who have some type of resistance or immunity from a previous COVID infection, we're actually into the low 50% range. And remember that we want to hit around 70–75% to really feel comfortable with herd immunity. But there's a pretty strong opinion now that our low rates really show that we're making a big difference in approaching herd immunity. This is an example of there are questions of how do we look for equity, and here's our equity map, and these are the total on the total. This bar graph in the upper right corner, these are total vaccine doses administered to the Q1 is quartile 1, quartile 2, quartile 3, and quartile 4. So you can see we're definitely doing a lot on quartile 1s, but not enough yet. And these are the zip codes basically throughout the county in terms of which are quartile 1, 2, 3, and 4. You can see this is the color code. Quartile 1 is red. Quartile 2 is I don't know what that color is. Is that beige or salmon or something like that? Light brown. So we're really focusing on those. And then light blue is quartile 3, and dark blue is quartile 4. So we're really focusing on quartile 1, some on quartile 2 as well. And that's really important for the reasons I talked about. So let's talk a little bit about hesitancy. It's well known that right now there's a certain percentage of our people. Basically, there's the vaccine uptake is skewed. Spanish dominant Latinos it's only 4%, and it's very low compared to all adults. 19% in terms of hesitancy. And a majority of Spanish-speaking Latinos, 55%, and a high percentage of Asian are very likely to get the vaccine, but only 31% of our African Americans feel the same. This actually is getting lower. We're making a difference, and it's estimated about 20% now are really vaccine rejectors. The rejectors, we're not. We're not that we're giving up. That the vaccinations are open to them, but we're really going to focus on the 20 to 25% of the state population who are undecided, who are doing it either to watch and make sure that it's okay because it's semi-new, or they're just waiting and hesitating. And it's clear cut that the demographic studies have shown that personal physicians, CDC, and family friends are the most trusted sources. And this is what we have to hit. And that's really what I'm appealing to all of you and to really chip in. And the Medical Society is going to develop a program of communication of the physicians to their patients to be a resource and to actually provide the vaccine. We've got more vaccine now. You know, you guys all remember when we didn't have enough vaccine and everyone was lining up. Well, we've got way more vaccine than demand right now. So don't worry about that. We need to go out and get our patients and get them vaccinated. So we're going to need the docs and the medical society and the medical community to get out there and really talk and reassure our patients. So this is a little bar graph on the likelihood to get COVID vaccine, and this is by ethnic. So this is a total 18%, and the dark are the rejectors, what people are just not going to get the vaccine. The 25% are our targets. The gray are the ones that are basically supporters or already vaccinated. And you can see the Asian Pacific Islander, we have 27% of them that we can still turn over, and the African Americans up to 39%. I've seen others that has seen that actually come down to about 25%. So they're converting, and everyone basically, hopefully everyone understands that the lack of trust that the African Americans have had in traditional medicine, and it stemmed from the Tuskegee syphilis experiments, where they did basically a double-blind study on the natural history of syphilis, and deliberately didn't treat the control group and watched them progress all the way to tertiary and neurosyphilis, and it was cruel. And then there was the story of Henrietta Lacks, the HeLa cells, and how she was exploited, and her cells were exploited. So they've been a particular. We have in our county at about 8.9% are African Americans. So we're really working with faith-based African American. Can you guys hear me now? Can you guys hear?
Yes, I can hear you now.
Okay, because it says the host just muted you. I said someone doesn't like what I'm saying. Okay, so this is the number for the Latinx, and then this is the Spanish dominant Latinx. So that's the numbers. So I want to talk a little bit about the variants. And the variants, basically, the faster the virus replicates, the more errors it makes. It's like, and I liken it to any simple task. Like it's not simple, but like if you were to bake a cake and you had all day to bake a cake, you make a pretty good cake to the best of your ability. But if you had to bake one cake every 15 minutes, you probably have a pretty messy cake and make a lot of mistakes. And that's the same thing with the replication of the virus. The faster it grows, the more it makes mistakes in its replication, and that's what the variants result from. So you'll see variants of interest are just those variants that have different genetic markers in terms of the receptor binding and transmission. We're just watching. They're just interest. Variants of concern show that there's definite evidence that there's increased transmissibility or increased disease severity. And then high consequence are those that basically have, there's clear evidence that prevention measures have significantly reduced effectiveness. We don't have any of high consequence right now, but I want to show you what's happened with the variants in our county. These are the known variants of concern. The B117 is the British or UK variant, and this is in California as of May 5th. And this is the South African, the 135, 67 cases. This is the Brazilian, the P1. And these two, the 1427 and the 1429, are the Bay Area, and there are quite a few of them in California. And I'm going to show you, this is really pretty dramatic. If you look at November 20th, look at how many B17s, the British variants, were in 0% of our isolates. And when you look at this is the Bay Area, we had 8.8% and 3%, and then this is the South African 0, the Brazilian 0. And now look at, as of April 21st, this is in California. 49% of our viruses right now are the British variant. 14%. Actually, we always combine, these are the Bay Area ones. So this is 20% basically, and we have quite a few of the South African, quite a few of the Brazilian. So they're here, folks. And there's another double variant, B1617, that's coming out of India. That's the double mutation. It's already been identified in California as well. And this is San Bernardino County, and 38% of our variants, of all of the viruses that we've done whole genome sequencing for, are now British. So it's kind of taking over here, and 44% are the Bay Area variants as well. So, and you can see we in San Bernardino County we have Brazilian, and we've got the two New York variants as well. That's the scary thing. That's the reason we have to continue vaccinating, because and the good news of all this is all three of the vaccines confer enough coverage to basically confer immunity to all of these. That's the reassuring thing. But the scary thing is there's more variants. Obviously, look what's happening in India, and it scares the dickens out of all public health people, because we just hope that there's not this horrible variant that's going to come that is going to have to stimulate a new vaccine. So I'm going to end the vaccine stuff with this is basically this, and myturn.ca.gov is the way to for our patients to sign up for vaccines, and for providers, and Soteria and the Medical Society are helping our providers sign up as well. And there's the federal pharmacy program, and it's vaccinate.gov, that they can also sign up to get in through CVS and through Walgreens and Rite Aid as well. So I'm going to stop this now, and I actually now want to take you to another epidemic that's happening that kind of continue to percolate and get worse during the whole COVID crisis, and that's congenital syphilis. Those of us in medical school learned about syphilis. It's an old disease, and it's treatable, right, with penicillin. And so what's going on? We should have this nailed, right? By the way, are you guys getting the congenital syphilis slides? Great. Okay. So we don't have a lot of time, and actually, I want to use this to actually stimulate the interest in the medical community, because we have a whole division and our specialist Tasha Lewis, who's actually on the line. She was a CDC fellow who came to public health, and she specializes just in syphilis and congenital syphilis. And we're offering symposiums to hospital emergency departments, OBGYN and family practice groups to be able to bring everyone up to date on screening for congenital syphilis. Let me just take you through a little bit of the epidemiology and slideshow. So this is the incidence within California of congenital syphilis, which is, and this is early syphilis rate, the significant growth. And we're dark. This is a number of counties. This is our county. We're in the top 7 of all the counties with 10. The number of cases 10 plus. This is our rate in our county, and you can see the significant rise, 1920, and this is probably artificially low just because of the reporting, because of the COVID. But you can, there's been a 900% increase in syphilis and congenital syphilis within our county, and babies are being born with severe brain and bone and systemic damage, and even sepsis from syphilis, and it's completely avoidable. It's so treatable. So again, this is a look at the number of pregnant syphilis cases, number of female syphilis cases, the number of congenital syphilis cases, and you can see that the significant rise. This is 2020. I mean, really, the 66 cases of congenital syphilis, which really 66 cases that were completely preventable if we could have just done syphilis screening on our pregnant women. And I'm going to continue on. We looked at maternal risk factors and barriers to treatment, and this is 2018, but 25% of these people, these pregnant women, had just limited prenatal. Basically, 25% had no prenatal care, so we didn't have a chance of these. We had a chance here, and 50% had some type of prenatal care, but did have social impairments, basically either drug use, homelessness, mental illness, no transportation, all these social determinants of health that public health needs to work on, no health insurance, or they were incarcerated. So significant impediments to picking these up. This is the issue. The top of it is common provider pitfalls. We've got miss after miss after miss, and we tried to trend them. So the first miss is just issues with syphilis testing. There really should be either traditionally you get an RPR, and then you have to follow it up with a confirmatory test. The RPR is a non-treponemal antibody, and the confirmatory tests are the treponemal antibodies, which are basically like the PCR tests. And then to get a qualitative RPR, but not getting a quantitative or titer of RPR. We've now instituted basically a recommended reverse sequence where you actually do the EIA, the immunoassay, which is a cheaper test. It's a lot more sensitive, but not as specific. So its negative predictive value is really high. It's above 91%. So if you can screen with an EIA, and if it's positive, you follow up with an RPR. That's the best way to confirm it. And then there are problems with staging, either signs or symptoms. Patients not asked about signs or symptoms, and they're not aware of the criteria. Physicians and providers are not aware of the criteria to be classified as early latent syphilis. And then basically the treatment guidelines were not followed. There's either the wrong medication. Alternative medications are not appropriate for pregnant women, like doxycycline, and if they have a penicillin allergy, they have to be desensitized. And there needs to be a strict 7 days, basically for latent syphilis. So they have no symptoms and they're pregnant, we consider them latent, and we basically give them 2.4 million units of bicillin every 7 days times 3, and that's the way to treat it. And we desensitize them if they have a pen allergy, and we have great protocols for that. So it's not difficult, and it's very safe. And then reporting practices. And I wanted to talk about that. And also, the other thing that we're seeing is that patients are getting, they're either not getting an STD and HIV panel at the first prenatal visit. That's a law, by the way. And pregnant at delivery, they're not, they're tested, but then they're discharged before the results are known. And we've actually had it, some of our magnet hospitals have even had issues with this. Oh, okay. Because of COVID, et cetera, we're having mothers brought in, they're delivering, and they're discharged quickly, and they're discharged before the results are known. And so we've got to go and chase the baby and bring them back to get them treated. And then we've got issues with noncompliance with homeless, IV drug users, no health insurance, et cetera. So in terms of preventing congenital syphilis, there's pre-pregnancy, there's screening, diagnosis, and there's timely partner services, of course, and highly effective contraceptives, of course. And then during pregnancy, there's a linkage to prenatal care, timely treatment, and timely partner services, and getting them linked with case management. And then at birth, there's evaluation and treatment of the baby. We have to test the baby and treat as well. The baby has to be treated IV with IV. There has to be a long bone survey. It has to be an LP to rule out neurosyphilis, and the baby gets treated with IV penicillin for 10 days. So remember, there's a law. All pregnant women should receive routine prenatal care, which includes syphilis testing. It's required by law that pregnant women get tested for syphilis on their first prenatal visit. And this, in the emergency department, they frequently get vaginal bleeds, rule out spontaneous abortion, and that may be the first visit. And so we're encouraging the emergency departments to get HIV and STD testing. That's the first prenatal visit. And that's the key, is we have to test. We have to test people. And then women who are at high risk for syphilis live in areas of high syphilis morbidity. And our county is an area of high syphilis morbidity. So we really have to screen for them, especially if they've previously been untested. So they have to be tested early in the third trimester and at delivery as well. And then screening recommendations, basically, no infant should leave the hospital without the maternal serologic status having been determined at least once during pregnancy and again at delivery. Okay. If mothers present at delivery with no prenatal care, you have to do a stat RPR. And if the baby has congenital syphilis and is asymptomatic, there's still an opportunity to treat the infant to prevent further morbidity. And any woman who delivers a stillborn should be tested for syphilis, because there's a high rate of stillborn with maternal syphilis. Our toolkit includes this serologic screening algorithm. This is the traditional, where you get the RPR and get a titer, and if it's positive, then you get the treponemal test, the TPPIA or the TPPA. Okay, and there's the new recommended reverse sequence where you get the EIA or the CIA, which is a treponemal test, and if it's positive, then you get the quantitative RPR. Okay, and we have a whole toolkit that all you have to do is let us know, and we'll deliver it to you. That includes all of this and a lot more. So these are syphilis treatment guidelines. They're pretty simple: primary, secondary, and latent. If it's early syphilis, early latent, less than 12 months, benzathine pen G and 2.4 million units IM, 1 dose. And if it's late, greater than 12 months, it's 3 doses at 1 week intervals. So I could go on and bring you back to med school days about how this is basically just a quick tour through what we have in terms of the presentation we'd like to present to all of your providers. We'll go out to hospitals, medical groups, OB. We really want OB and primary care to really go through a refresher course on primary, secondary, tertiary syphilis. We've got some great educational materials. This is primary syphilis, the chancre, both vulvar and penile, and the duration 2 to 3 weeks. This is secondary syphilis. Remember the plantar lesions, the palmar lesions, the back, and the condyloma. This is vulvar and the alopecia. And then the latent syphilis, which is hidden and has 2 phases, early and late. And tertiary syphilis can appear at 10 to 30 years after infection. So if we don't catch it, it continues to grow and it can affect multiple organisms and can be fatal. And of course, neurosyphilis basically has significant late complications. And we're seeing neurosyphilis folks in this county, and we've seen them present early in their phases as well. It's a great example of ocular syphilis and a fundoscopic view of that. And congenital syphilis, I'm just breezing through this, and I don't expect you to retain all that, but I want to basically give you an idea of what we have in the toolkit and what we want to bring to all the groups. And congenital syphilis, basically, it's transmitted from mom to child during pregnancy. It can cause severe illness in the babies, including premature birth, birth defects, blindness, hearing loss, even death. And we've seen sepsis with this as well. It's very preventable with timely diagnosis and treatment in pregnant women. And these are some of the things that it's a clinical diagnosis in addition to a lab diagnosis. So they call this snuffles, this significant, severe discharge from the nose and mouth, and they're basically snuffling constantly and crying. The cutaneous lesions, the desquamation, and the plantar and palmar lesions. This is an example of the syphilitic rash. And with every baby that's born with a positive RPR, you want to do a bone survey, and they have significant bony changes as well. And they grow up to have these saber shins. This is the teeth that they get, the Hutchinson's teeth, perforated hard palate, and even get a keratitis from this. So I'm going to end it with that so that we can have some time to talk. We have 15 minutes, and I've already gone basically through the epidemiology of syphilis as well. So if I haven't answered any questions, by all means, is it Soteria that's going to?
Yeah. So basically, thanks, Dr. Sequeira. That was really amazing. I wish the whole world could hear this, because I think we'd have a lot of people who'd wake up to the reality of public health. But anyway, that was amazing. Thank you so much. So yes, Soteria Cobb is going to facilitate our questions. And what we're going to do, we're going to go through the questions in the chat right now, because we have all of you on the line and you have submitted those questions. Then once we get past those, we're going to go through a couple of questions that were submitted in advance. So Soteria Cobb, I will introduce my colleague, our membership director, Soteria, who's going to start with our chat questions.
Okay, perfect. The first question that I have is, any update from CDPH regarding front door temperature screening for outpatient clinics in San Bernardino County?
Yeah, that's a really good question. And before I came on, the public San Bernardino County Public Health has issued an AFL all facilities letter basically stating that temperature screening should be done with front door screening, and many of the local health jurisdictions have released the temperature screening. There's still very active proponents within the county and even in the state that state that if we were going to check at the front door, we should be checking the temperature anyway, because you're asking about fever. So right now, some of the health jurisdictions have released the facilities from doing temperature screenings, and I even heard in the news that Disneyland and Universal City are not doing temperature. We're discussing that actively right now, so that expect some action, but right now it's still highly recommended within our county. So.
Great. Well, the next question is, if the county will no longer have to follow the tier program, will we still have to contract trace at school sites?
Yeah, that is the whole basis of public health and epidemiology is surveillance. We've gone from surveillance to catastrophe, to control, to vaccination, and to now we're controlled. So we have to kick into surveillance mode again, because if we don't do testing, we're not going to be able to pick up vaccine breakthroughs and the emergence of variants and breakthrough infections. So please, yes, absolutely. Patients who have continued symptoms, and if you're in any way thinking about it, order the PCR test. That's the only way. There's certain labs like Fulgent in our state lab now who the volume of testing is so much lower that they're doing whole genome sequencing of every positive test, and that's really the best way to survey, to pick up the variants and breakthrough infections. So.
Perfect. The next question is, how come there is no information about J&J vaccine with contraception-induced CTV?
There's probably no data because none of the women actually were on contraceptives, but in our fact sheet, we actually recommend that women who are on any type of estrogenic compound, whether it be birth control pills or an estrogens for treatment of breast cancer, et cetera, should not be getting the Johnson & Johnson if there's a choice. The incidence is probably higher than the incidence in women in that the higher 30 to 50 age group. But so we're recommending if there's a choice and it's a woman in a childbearing age or up to the age of 50 who's on birth control contraceptives, that they probably not choose Johnson & Johnson. And they're not, we're not going to see studies on that. They're not going to run try to look. That's another Tuskegee if they put women on birth control pills and give them the J&J to see true incidence. I think to me that's all we need. And if we had to, and there's no other choice, and it's in a high epidemic area, then I'd say the odds are still very low. But I would, especially if they're on birth control pills, I'd choose another vaccine.
Great. How long are these vaccines going to last, or vaccinations going to last?
Great question. So far, we've looked up to 6 months, and the immunity is solid at 6 months. So that's all. We can say, it lasts 6 months, but it's really so far as long as we've been able to measure. So chances are, in much better minds than me, like Dr. Fauci and Dr. Walensky of the CDC have estimated, we're probably going to look for boosts at 1 or 2 years. And if you know the mRNA technology, it's so easy for them to produce a booster to any. They basically take the viral genome, and then they lay out and make a messenger RNA strip that codes for that spike protein, and then they put it into the liposomes and inject it. It's going to be really quick. So the technology is already approved. So that it's like influenza. If we get an update booster, boom, they'll be able to produce it really quickly. So I'm really confident in that.
Great. The next one is, do you have any data on the hospitalization rate, positivity rate for 18 and under pediatric cases of COVID-19 in the past several months? Since we are talking about a push to vaccinate children 12 and up or even younger, parents are definitely hesitant to vaccinate their children when the rate of hospitalization and death in the pediatric population has been so low throughout the pandemic.
Okay, it's no longer low for this reason. Children TK through 6 or up to age 10 have a lower incidence just in general, and there's a scientific reason for that. They have much fewer ACE2 receptors in their nose and mouth, so they produce much better antibodies naturally. But from the age of 10 to 17, that age group now accounts for close to 20% of our cases, and it's because they're the reservoir now. We've vaccinated many more people above that age. So they're the reservoir of the virus right now. The incidence in adolescents and early 20s patients really is highest of all the age groups. If you look at 60 to 65 now, it's much, we've got close to 70% of that age group already vaccinated, and the incidence is much lower. So we're chasing after the virus. We're trying to eliminate the last reservoir of infection. When we looked at it through all age groups, it was lower, but now that we've vaccinated the higher age groups, it's now higher. That makes sense.
Mm-hmm. Okay, the next one is, I did not hear about vaccines being effective against all variants.
Yes, and I've been following that very closely. And the variants, including the South African and the Brazilian, definitely have increased transmissibility and resistance to the vaccine. But the resistance is only about anywhere from 25 to 45%. The vaccines stimulate such a robust production of T cell, killer T cells and antibodies that it easily overcomes that. So every variant that we've seen so far, knock on wood, including the double variant, the B1617 from India, so far the vaccines have conferred protection against them. So that we want to keep it that way and keep vaccinating. So there is data. It's not published as in the the New York Times as much, but I'm following it through New England Journal and journals of the immunology. So
great. This next it's a comment / question from Dr. Roloff. It says, thanks for talking about congenital syphilis. As an MFM physician, it's a disease that we've never thought we'd be experts in, but now we've had to learn. As you pointed out, many diagnoses are too late for us to impact neonatal health and damage is done. In order to eradicate this disease, we need to screen all of the population before pregnancy, men and women. Does DPH have any campaigns to increase screening in the general community? Can we make syphilis screening part of the annual exam?
Thank you, Dr. Roloff. And what perfect timing that we have you coming on as president-elect, because this is what I'm planning, and we are planning a big program for congenital syphilis and syphilis and STDs in general. So I would love to work and have the medical society and public health work together in developing a systematic program. This is the beginning. I'm going to present also to all of our public health clinics, the FQHCs, and then what I want to do is plan out an educational program. And Tasha Lewis, our program manager for syphilis and congenital syphilis, she's a whiz, and she will do provider detailing for all your physicians and physician groups. So absolutely, we need it. We really need to work hard on this because it's rampant in our community.
Awesome, thanks. Looking forward to working with you on it.
Yeah, me too.
And Tasha Lewis went ahead and added a comment. If anybody is looking for congenital syphilis provider toolkits or educational presentations, to contact her, and her email is listed in the chat as well. And the next question, or actually the last question on here, is what is the role of checking antibody levels?
This is a good question. I'll give you a little quick anecdote. My partner Betsy, this is in like February. She got this bad flu-like illness, and no, it actually was January, and this is before it was really that known. And she got a little better, and then she just suddenly said, "Wow, I can't smell and I can't taste." And I said, "That is so peculiar. Is she like being neurotic or something?" Or don't tell her I said that. But but it eventually went away, and then of course this came on COVID, and then it just hit me. Oh my God, she had she had COVID. So we went and got her antibody levels done, and they were negative. And clinically, she had COVID. But we tested her twice. And when you look at the nature of immunity, especially to viral infections, and this goes way back to immunology, but basically, our body's defense to viruses and cancer are T-cell mediated primarily. Our body's reactions to bacterial infections are antibody mediated. So it's very easy to see that a patient can have basically kicked a viral infection and have negative antibodies, because the key is the memory T cells and the killer T cells. And we're developing actually tests for those. And those are the keys. And it's the memory T cells that actually have the memory too, so that later on, when you get this, like with tetanus or hepatitis, etc., it's the T cells. So that's the role. We have neutralizing antibodies, which are important, but they bring in the T cells. So.
Great. We actually just got another question. It
Okay.
says, what are the recommendations with regards to having kids on campus for public schools? What guidelines should be followed, if any? If they are having some of the symptoms of COVID, should they be sent home?
Yeah. Currently, we're opening up schools, and we public health Heather. Heather Cockrell is our liaison, is working with all the school systems and opening up our schools. So we're not necessarily doing required testing anymore, but if patients are symptomatic, yes, they should stay home. Yes, they should be tested. But by and large, the social distancing within schools has been decreased from 6 to 3 feet, and they're still cohorting. But as of June 15th, everything's going to kind of open up. So, but still, if children are symptomatic, they probably should be sent home and tested and not return until they're negative. And if they're positive, they should stay home for 10 days, of course.
Okay. Well, that's all that I show in here for now.
I wanted to make sure we didn't.
Allison Soteria, give
Yeah.
me 2 seconds. I'm sorry.
Hi, Dr.
I'm
Lane.
so excited that you are a public health officer. Let me just say that up front. But the hesitancy and the lack of trust of the African American community is amazing. And when I was president of the Medical Society, I created the African American Health Initiative, and nothing has changed. Prostate cancer, breast cancer, and now the suspicion of vaccination in the African American community is frightening to me. What can we do? It was wonderful to hear you say, that we need to deal with the churches and the ministers. But what can public health and physicians do to mitigate this distrust?
Yeah. You raise a great point, and we have to accept that that's there. And what we're working with is we have to work with our African American physicians, number one, and our faith-based communities, and really work on this whole issue of structural racism, and it has to deal with all these social determinants of health, and that's the kind of the crux of population health, is those social determinants of health: food insecurity, money insecurity, housing insecurity, all basically lead to high incidence of MI, stroke, hypertension, congestive heart failure, COVID. It's all linked until we have a systematic approach to that, and that's what we're working with. We've got got to deal with
Okay.
all of it. But
It's a big problem. I think
It is.
it's a big problem for organized medicine because I think we need to regain the trust of the African American community. And your presentation was wonderful.
oh,
Mhm.
thanks, Ken.
Thanks,
Wow,
Dr.
you've had-
Oh, I was just going to say, Dr. Sequeira, there was one more comment. I didn't want to ignore Dr. Prasad's comment here. It didn't have a question in it, but I would like to just make sure you read it. She says the Indian variant, the double mutant, preliminarily shows neutralization with ABS from vaccinated people, Pfizer. They're behaving similar to the single mutant variants in preliminary data.
Yes, and I bow to Dr. Prasad. She's one of our experts in our society, and thank you for that, Dr. Prasad. Yeah, I was really gratified when I heard that, and we're just holding our breath, though.
Okay, great.
We have another one in there. Do you want me to go ahead and read it, or do you have time?
Oh yeah, yeah.
Oh, okay.
Absolutely.
Okay, great. We do have one, another one from Christine. It says, in addition to that, will schools be required to still have separate isolation areas on campus?
Good question. Probably not. And you know, with the June 15th, it's called Beyond the Blueprint. But I'm going to bow to my school experts on that. But it's unlikely that they will. Yeah, we were cohorting them. You know, the cohorting and keeping on the size of 16 or less, and now the cohort size has been expanded. And you know, the whole concept of cohorting is keeping, you know, basically they interact only with that certain group. But you know, we're isolating if they're positive at home, and then at day 10 they can come back to school. So good questions though, and things we're going to continue to have to deal with. But I'm hoping that we actually get, you know, with the medical society, you know, I really want a program out there to really approach your patients with vaccinations and with the whole issue, and maybe even, especially if you're in the quartile 1 areas of your practice, just to get out there with a campaign, screen every patient, have you been vaccinated, and maybe send out surveys to your patients, and even sponsor vaccine days, or get together with a group to sponsor these days. And like Dr. Lane had mentioned too, you know, that if you've got a high percentage of African Americans in your practice, we really need you to reach out and reach out if you feel more comfortable with an African American physician, but we need to reach out. This is a time now where we're going to dig deep and have to get those patients out there to vaccinate. So, and we're going to work with Dr. Roloff on the syphilis thing next year.
And we did get another question. It says, is there any mobile clinics to offer vaccinations for people experiencing homelessness?
Absolutely. We've actually got a few strike teams that are out there. Arrowhead Regional, Rod Borger, and Dennis Tankersley, his lead PA, have recently developed. We're developing a program with them that basically are going to homeless camps and just vaccinating them. And we're also looking at we're working with the homeless agency. There's 3 different areas within the counties and we're working with them to basically identify the high areas of the homeless population, and we're sending mobile teams out there for sure.
So Rita, let me say a point. There's a field of medicine called street medicine. And if you go to streetmedicine.org, you will learn about what we're doing to take care of the people that are homeless. We have 3,000 students in San Bernardino County that are homeless. And James Ramos is a huge supporter of doing what we can to support the homeless. But all the physicians, if you go to streetmedicine.org, it's going to change your life. Sorry.
Not at all. It's great. And I've actually heard of it. And actually, this group that Dennis Tankersley that has worked with them in LA County, and they're bringing those concepts. But Ken, I'm going to be calling on you to work on this problem.
Mhm.
That's right.
I see the passion. I love it.
We
what we
do
need.
have some questions that were submitted in advance. So how you want to spend the next 7 minutes is up to you, Dr. Sequeira. Would you like us to read any of those questions? Or I think you may have a copy of some of those, or how would you like to, or do you have any other comments you'd like to make?
It's totally up to you guys. If you see the questions, and Soteria,
Yeah. Maybe we could start with a couple of those Soteria and
Sure.
you can present those to Dr. Sequeira.
Sure. Let's see. What is being done to reduce vaccine inequality?
Yeah, I think I dealt with that. Remember we
Earlier.
went through all the
Okay.
zip codes and
Equity.
Yes.
quartile ones.
You did great.
Oh.
Mhm.
I think
Okay.
that number 4, I think people.
Do you want me to read it?
Yeah, go ahead.
Where do you recommend we send people for vaccines that do not have photo ID, such as undocumented people that may be fearful?
The county clinics. We absolutely have dealt with this, and we made a full commitment. We're we don't want our undocumented population to not get vaccinated. So we are not going to challenge them. We just want an envelope to show that they live in San Bernardino County, and we're going to vaccinate them. We absolutely have to do that.
Mhm.
Right. Okay, do you want a question there, Soteria, or Dr. Sequeira? Do you want to choose your questions?
I think how about number?
Because you did kind of cover most of these.
Yeah. Number 8. I want to get the opinion of some of the people.
Okay, how do we get the parents to vaccinate the children and safety of the vaccine in children?
Any pediatricians? Dr. Baum, is she out there? It's really important. And what we're doing is we're sponsoring town forums with the schools, informational sessions, and really working on that, because mothers are parents are ultra protective of their children. That's the paradox of COVID, though, right? Because influenza hits children much more severely than adults, but COVID actually hits children much less severely. So my thought, and so far the vaccines for the 12 to 16 have been 100% effective, and so it's extraordinary, and I really anticipate it's going to be extraordinarily safe and effective in children. And we just have to prove it to them. Most of the socially conscious and basically appeal to. Some of them are going to be, the rejectors, and they're going to just say no. Like that group of Orange County parents that were this morning were in the news saying, "No way will you force me to vaccinate my children." And, they feel very righteous about it, but we need to keep offering. That's the problem. When we need to get to 100%, we need to keep offering.
Yeah.
One of the questions that did come in that wasn't on the list that I had sent you, it was right before we started the call. Is there more support for our county's public health infrastructure now to face possible epidemics, pandemics in the future? Why or why not?
Yeah, great question. And yes, there are currently about 7 bills in the legislature, actually. One, and we'll be hopefully supporting a few of these, but like AB 360, I believe, but which basically looks to evaluate the infrastructure of public health. But we've learned a lot. We obviously can't ramp up and and staff and supply for a pandemic level, and that's where the understanding of public health has to come in. There's a baseline surveillance capacity, and there's a prevention capacity, and then there's a social determinants of health capacity. And we've got the environmental part of public health, where we're looking at the restaurants and safety, and then we've got the communicable disease portion. So we've got to be able to have a hefty enough or robust enough capacity for surveillance, and then a response to that surveillance that would include disease investigation and contact tracing. So we've really learned, we're really going to put in for stockpiling more PPE and rotating it so that it stays fresh, because California had a huge supply of PPE, and then it all went stale because it wasn't used and wasn't rotated, and they got rid of it, and then the pandemic hit us, and it's those kind of lessons that we'll hopefully learn, and we're sharing a lot of that right now. There are a number of different seminars put on by CDPH on what can we do. So
Fabulous. Well, is that I think that pretty much, Dr. Lane looks like
one more point. I want Dr. Sequeira to know how much I appreciate what he did with San Bernardino Valley College. We have athletes, we have teachers, and we have students, and you approved a vaccination site on campus, and that's amazing. Thank you.
Oh, thanks, Ken. Yeah, and we definitely want to get it out there. So we appreciate
Thank you.
You're paving the way. It was,
the thing about sports is they couldn't have sports because they couldn't.
Uh-oh, you're freezing, Dr. Lane.
Students 6 feet. Thank you.
You froze a little bit.
But you're right, and the other thing is you guys probably are aware of is all the Cal States in California, all of the University of California campuses. Basically, as soon as the FDA gives full approval of these vaccines, they're going to require vaccination for matriculation, and I love that. Right now, we can't require and mandate vaccination because anything that's under EUA or emergency use authorization cannot be mandated because it's still experimental under emergency use. But it requires 6 months of data, and we've got 6 months of data. So the Pfizer and Moderna are applying for full FDA approval. Once we get that, then we can really require it. So right now, it's all mandatory. Like Dodger Stadium has a section just for vaccinated. The SoFi Stadium in Inglewood just had is that a cat, Ken? That's very cute. I have Van Gogh here. Van Gogh is a deaf cat that has the loudest meow, and he has we call him Van Gogh because he only has one ear, but and he's a polydactyl. So.
But the thing about sports is they could not have sports at the junior college or high school level because you couldn't put athletes within 6 feet of each other. So you'd have to have 20 buses. With vaccines, they're on one.
Yeah, yeah. So hopefully that's the kind of thing that we have to just emphasize everyone to get everyone vaccinating.
Well, that was really, really outstanding, Dr. Sequeira. I think clearly everyone really enjoyed that. We really, really appreciate all your time and all of your expertise, and that you chose to share that with us tonight. So, I think we can all say we'd love to do another one of these in the future. Maybe we can update. I know there are still so many questions, like what's going to happen with airline travel, and will vaccine passports be required? And I know Soteria, your test is out of California, but you're talking about your daughter, her college campus is requiring all the students be vaccinated. So there are a lot of issues that we're still that will still be developing, I think, that we can maybe talk about next time.
Absolutely. I'm with the Medical Society. I'm with you. I'm available.
Well, we are grateful for you. So thank you for the partnership. That was just really, really much appreciated and outstanding. And thank you so
This
much
was,
to
yeah.
everyone who joined us tonight. You know, and I just want to say thanks for standing strong through COVID and continuing to provide such wonderful care for your patients. So it's because of all of you that these folks are staying healthy, and we have, you know, good solid footing here in our community and our region. So we really appreciate all of you.
And thank you to the Medical Society for stepping up. That's, you know, we really shown leadership during a medical crisis, and that's the way to show up.
We appreciate the guidance that you've given us on that. So, all right. And don't forget, everyone, if you would like Dr. Sequeira or his team to come and speak, do a presentation for you on some of those topics he referenced in the syphilis issue, to reach out to either him or one of us on staff. And I did put our contact information in the chat for those of us on staff at SBCMS. Just reach out and we will get in touch with Dr. Sequeira for you.
Absolutely.
All right. Well, thank you. That was outstanding.
All right.
Enjoyed it.
Take care.
Thank you so much.